Hello. We actually want to start. Would like to give 2 more minutes. That means we'll squeeze our session into time, less 10 minutes. Because we should have started at 1:30, 13:30, but it's coming to 13:40. We still have yes, I see we still have people walking in. I don't want people to miss this session. The panel is going to talk about practice, implementation, from theory or research to practice or implementation. Yes. So let's give ourselves just 1.5 minutes more and we start. I'll also try to mobilize from outside. Maybe there are people interested who have not yet come in. It's waiting for you. So should we begin? Okay, let's start. So my name is Robert Kanwagi. I'm your moderator for this session. I work with the London School of Hygiene and Tropical Medicine. Previously worked with Gavi as the demand generation advisor for COVAX. Happy to be here. I would like to thank the organizers, Sabin Institute, Gavi, and all the extended partners who have contributed to this conference. And the session that we have today is a session about the complexities of vaccine equity. We all know what vaccine equity is. Vaccine equity means that everyone in the world has equal access to vaccines. The question is, does that really happen? That is the desirable, but does that really happen? So we want to explore with my panel, representing 2 different continents, Africa and Asia, to take us through their experiences on how they have translated the research, the evidence, the theory that enables you to achieve vaccine equity into practice. What actually they are doing in the field to overcome the challenges, the problems, the difficulties, the twists, the turns, the entanglements that could undermine equity or vaccine equity. And my panel has a speaker from Indonesia, from Nepal, from Nigeria, from Ivory Coast but working in DRC, and from Uganda. So it's a very interesting panel. So you're going to hear experiences from 2 different continents and about 6 countries. So I want to kick off the presentation by inviting our first speaker. Our first speaker will be Yulianto. Yulianto is from Indonesia. He's a medical doctor. Thank you for coming. We have slightly just started. We still have participants coming in. I was saying we have slightly just started, so you have not missed anything. I'm just introducing our first speaker. So Yulianto will take us through. He's a medical doctor specializing in child health. He has graduated from the University of Indonesia. He recently led a 2-year national risk program on COVID-19 vaccines in Indonesia, funded by DIFA. The program has been able to achieve increased access to both COVID-19 vaccines and routine immunization. And he's going to share with us his practical experiences on how they have increased in their program access to vaccines amongst the disabled communities. Thank you, Dr. Yulianto. You can come and speak.
Hello, my name is Yulianto. Thank you so much, Robert, for the introduction. We work in Indonesia in 5 provinces. We work with people with disability. We learn so much from people with disability, include the sign language. So my introduction using Indonesian Sign Language. So as an introduction for all of you. And then I will invite all of you to take a quiz. Do you agree? Okay, but without a prize. From our plenary today, we learned so much from India, from that people with disability have difficulties or challenges. We learned so much from our people with disability organization in Indonesia. So I will ask to all of you, which picture do you prefer when you interact with people with physical disability? This one or that one? If you choose this, raise your hand. 1, 2, that? Okay, almost 300. Okay, thank you. The next one, the same with blind people. When you interact with blind people, which do you prefer to act? This or that? This, raise your hand. Okay, almost 500. That? 300, okay. Would you like to know more about this? If you want to know more, raise your hand. So you will have the answer after my presentation. Okay. So we work in Indonesia. We work in 5 provinces. We conduct inclusive vaccination because inclusive vaccination is one of the results of our initial research to narrowing the operational gaps. We know many barriers when we want to reach people with disability. So this is the practice base. We will share to you what we have been done in Indonesia regarding last mile COVID vaccination. We work as a program. Australia-Indonesia Health Security Program is a 5-year program. We work to strengthen the health system in using the framework prevent, detect, and respond and coordination. We work in 5 provinces. In this presentation, I will focus our program in South Sulawesi. So as a background, we know that from the plenary today, there is a demand side and supply side challenge. In Indonesia, in demand side, you can see that in the dashboard, there is no disaggregated data on women, on male and female, and especially for people with disability. So if there is no data, there is potentially exclusion for people with disability because they have not seen in the national dashboard data. We also conduct research. So from the plenary, we know that we need to listen. We need to listen more. So we listen from participants, people with disability in Indonesia. So the same challenges that we found in Indonesia and in any other countries, I think, from India, from Africa, that the man who is blind said that there is no communication of benefit of vaccines. So, and feel forced to get vaccines. And then discrimination, and never inform the explanation on vaccine. For people with physical disability, there is no time to attend the regular schedule of vaccination in community health service. And then from women who is deaf, very scared because no interpretation. There is no sign language interpreter in every health event or every vaccination event. So for elderly, they feel that a long queue, when they attend a vaccination event. So in demand side, we have unseen in the dashboard. In the supply side, there is unmet needs from people with disability group. So our last mile strategy is we built from those findings. We develop the 3 stage. We advocate because we know there is a problem in demand side. And then we activate the network because we know that nothing about us without us. So we need to develop the network, people with disability, government, community, media, university using the pentahelix approach, and also inclusive approach on vaccination event. So if you are familiar with 3C, convenience, complacency, and confidence, so we do the advocacy, we do the network, and we pilot the inclusive vaccination event. So after we piloting, we can show to the government, to all participants, this is the best way to outreach people with disability. So in practical way, we conduct data identification like focus group discussion. In data identification, we raise the awareness from the government. We build trust from people with disability organization because from yesterday we know we need to build trust. If we invite the government, we give access, we facilitate people with disability to talk, to facilitate the event, to share their stories and experience, it keeps the emotional engagement from people with disability and also government. And also we build commitment. So this is the importance, the data identification meetings that comprise all stakeholders. And then we built even the committee to grab the attention and commitment. We adapt a guidebook and inclusive IEC materials. And then to have more broad structured commitment, we conduct audiences or coordination meeting with district head government. Then conducting promotion, technical arrangement with all various stakeholders who will join into the vaccination inclusive event. And then publish in the media. We learned that if we publish all the activities in the media, we will gain trust. People with disability will trust you if your event published in the media, in the local media. And then the government will have commitment because what they have been said is published in the local newspaper. So that's our strategy. This is the first event. The FGD focus group discussion in South Sulawesi. We discuss the importance of data to reach people with disability. And then we invite people with disability organization to facilitate an event, how to interact with people with disability, how their experience on vaccination, and it improves the awareness of the government. And then we engage multi-stakeholder. This is the example of the stakeholder. We use the pentahelix approach, so the government, the community, media, university, and also private sectors. We develop the the inclusive risk communication materials using audio visuals, audio only, and also printed materials. And this is, if you have vaccination, the doctors will screen you, will ask you questions. Do you have hypertension? Do you have allergy? In Indonesia, the question is listed in the printed words, so we adapt into pictorial. So when the doctors ask about the allergy, we bring the picture around the anaphylaxis. So it will be easier for the medical doctor to ask the screening question for vaccination. Because when you screen people with intellectual disability, you cannot talk like this. You need to lower down your expectation and use the pictorial to explain more for people with disability. And then we also discuss during the FGD session, we adapt, if we want to build the inclusive vaccination event, we need to build the convenience place for immunization. So based on our experience and our discussion and inputs from the community itself, in the vaccination event, we built special line for each type of disability: sensory disability, physical disability, intellectual disability, elderly or older people with physical disability. And then there is a waiting section, the injection site, and the room to observe if there is any adverse event after vaccination. And then after we built the adapted guidelines to make the commitment consistent, this is what the team have been done. So have an audience meeting with the head of districts. We know in Indonesia there is many local agency, and it's quite difficult to make the discussion and ask all the agency come into one room of discussion. So the team went to all the agency, health agency, social agency, civic registration agency, and talk about the inclusive vaccination event, the result from the discussion event, and grab their commitment to support the importance of this inclusive vaccination, because people with disability have higher risk to contract mortality and morbidity if they contracted by COVID-19. This is the pentahelix approach from the government agency and from others organization that need to be engaged if we want to grab more for people with disability. From people with disability organization itself, youth organization, professional association, doctors, nurses, and also hypnotherapists, religious leaders, media, university, and also private sector. This is the invitation. So we conduct through the social media, the printed and also through text on WhatsApp group. So after building committee, the team built WhatsApp group to inform regularly, and then giving promotion through the radio broadcast, and then put it big poster in the public area in the district. Before we conduct the inclusive vaccination, we meet together and we discuss how to implement the event. So this is what we done in the technical meeting. But the most important thing is we can do the inclusive vaccination in any place. We can do in a public place. We can do in schools. All the committee commit to build inclusive event. So this is the ramp built by wood to put up from the stairs, so people with wheelchair can access the event. Okay. So this is the implementation. Special line, sign language interpreter. There is no additional money from the program. The sign language interpreter is come from the people with disability organization, because we involve people with disability organization since the beginning, since data identification, since the focus group discussion. And then if we want people come, the challenges is not only vaccine hesitancy, but sometimes if someone did not have any national identity card, so they cannot access the basic services. Then we collaborate with the civic registration agency to include in the vaccination event. So people who not have the national identity card can make the identity card and access the vaccination center. This is the local leaders. The mayor also come in the vaccination event. This is the wife of the region in South Sulawesi. She also support the event because the audience meeting and coordination meeting. And this is the most important thing is the local group. People with disability organization, people with disability organization and all the stakeholders. And we can reach 20% from all vaccine coverage is for people with disability. It's really difficult to have 20% proportion in a vaccination event that dedicated for people with disability. Please. This is my last slide, just 2 minutes.
Rumah jabatan Bupati Nrekang dibuka untuk seluruh lapisan masyarakat tanpa kecuali untuk menerima vaksinasi COVID-19. Kegiatan vaksinasi COVID-19 yang inklusif ini didukung oleh kemitraan Australia-Indonesia untuk ketahanan kesehatan dan merupakan bukti komitmen Kabupaten Nrekang untuk mempercepat mitigasi COVID-19 agar Indonesia lekas keluar dari situasi pandemi.
Sekira masyarakat di Indonesia, termasuk di Nrekang sekarang sudah betul-betul sadar, sehingga vaksin ini mestinya bukan kita yang harus mendorong-dorong, tetapi merekalah yang harus secara sadar untuk meminta divaksin.
Ya, kelompok rentan seperti penyandang disabilitas dan lanjut usia kerap tertinggal dalam hal akses terhadap informasi, pengetahuan, dan layanan kesehatan. Tidak semua memiliki kesadaran dan motivasi untuk melindungi diri dan orang-orang di sekitarnya dari ancaman COVID-19. Keluarga dan pendamping pun belum tentu dapat memberikan dukungan yang semestinya. Dan tenaga kesehatan pun belum tentu dapat berkomunikasi dan melayani dengan tepat sesuai kebutuhan mereka.
Halangan-halangan kami yang kami temukan di jalanan, di lapangan, ada kendala di mindset pihak keluarga. Hak-hak teman-teman disabilitas kadang diambil alih oleh keluarganya sendiri. Jadi penentuan sikap mereka itu kadang tidak terpenuhi.
Tetapi kegiatan kali ini membuktikan bahwa penyandang disabilitas dan lansia dapat dijangkau, dilibatkan, dan dilayani dengan sebaik-baiknya. Di lokasi, puluhan peserta dengan disabilitas mendaftar dan didata menurut ragam disabilitas. Saat pemeriksaan kesehatan, tenaga kesehatan memberikan keterangan dengan bahasa yang sederhana, didukung bantuan gambar dan ketersediaan juru bahasa isyarat. Efek samping vaksinasi atau yang diistilahkan sebagai kejadian ikutan pasca imunisasi atau KIPI juga dijelaskan melalui materi-materi audiovisual yang menarik dan mudah dimengerti. Peserta juga dapat menikmati sejumlah layanan publik lainnya secara sekaligus, yaitu perbaikan atau pendaftaran data kependudukan, tes gula darah gratis, ukur tinggi dan berat badan tubuh untuk mengetahui indeks massa tubuh ideal, serta hiburan musik dari teman-teman penyandang disabilitas.
Harapan saya jangan takut, silakan ikut vaksin pertama, kedua, dan ketiga.
Okay, thank you so much.
Thank you, Dr. Yulianto. Our next speaker is Dr. Djeneba Coulibaly-Traore. She is the project coordinator for the USAID-funded Momentum for Routine Immunization, Transformation and Equity. She has more than 20 years experience in the public health field with a PhD in sociology from the University of Berkeley. In this role, Dr. Djeneba supports programs that scale up COVID-19 vaccination programs, routine immunization, data system strengthening, and demand generation and communication. Dr. Djeneba is going to speak to us about the work she has done in DRC, in the urban settings of Kinshasa, and in the rural urban settings of the mining communities in Katanga and Kasai in DRC. And she'll take us through some of the underlying challenges and how they have overcome vaccine inequity in their programs. Please.
Good afternoon, ladies and gentlemen. How are you? Fine. It is a session after lunch, so it is always a little bit difficult to start. I hope we will be taking you straight to the point. So on behalf of the team of the Momentum projects funded by USAID in DRC, I want to share with you our experience in improving the vaccine uptake in the Republic of DRC by engaging what we call non-traditional partners. So, this is the content. So, what is the momentum? So, we, in the 3 years, starting 2001 to now, Momentum is, have been identifying and reaching to helping the EPI team to reach and support more zero-dose children. How you have seen since yesterday presentation that DRC is among the country with a big number of zero-dose children and also under-immunized children. So in the work we are doing, we also strengthen COVID vaccine rollout and facilitating innovative partnership to increase vaccine coverage, including multi-sectorial partner in those with community, living with communities. So this is what the background. When we started in September 21 in DRC, we were under 0.5% of coverage in total for the entire country. And we also had a kind of misinformation, I think, like in other countries also, but it was a little bit difficult there. And it has been exacerbated by hesitancy, but also the service availability was also a challenge. So what we did was trying to think innovatively, what can we do differently to engage and to improve the COVID-19 vaccination uptake? So the MRI projects collaborate with the DRC expanded program of immunization, the EPI to engage with non-traditional partners. First of all, by conducting COVID-19 public education and awareness campaign all over the provinces where we operate. And we did registered through this process when people willing to be vaccinated and also assisted to host what we call mobile COVID vaccination unit. So it was accepted, it was close to the community, the beneficiaries, and we start seeing some kind of acceptance. So based on the initial increase in the people registered and vaccination through their efforts, the project extended the approach to the routine immunization. We were very proud of the result we had, and we found out it is something we should also extend to the routine immunization. So learning from COVID to improve the routine immunization. So what we call non-traditional partner are the organization you can see, religious organization, there are healthcare workers association, women groups, private, public, and also individuals. So out of a total of 126 non-traditional partners we try to mobilize, we have realized that the activity was implemented by, like I said, 32 from Kinshasa, the capital city, and 23 in Okatanga, one of the mining province where people are very busy running for business, and also 24 in Kasai. Activity were implemented from August 22 through May 23. And we spotted COVID-19 and RI activities in these. So what are the steps follow for the non-traditional partners approach? So this is very important for you to know. We landscape all the potential non-traditional partner in, let's say, given community or city or where you want to implement it. And we conduct a semi-structured interviews to learn more about them and their communities. And third, we also have a co-creation, like we have been talking about since these days. The human-centered design is very key in this approach. So we do have it in a co-creation session where we discuss with them in deep, and the EPI and even the Ministry of Health local representative come and present what are their challenges, what are the key challenges for immunization. And we develop after that a kind of what we call action plan. And at the end of the process, this session is concluded by a signed contract or MOU between the partner and the EPI, not with the project, because we are just facilitating. We are not signing any commitment with the non-traditional partners. And fifth, we establish at the community level what we call a committee to oversee what is the non-traditional partner are achieving. And we, of course, implement and monitor the action plan, and which can be adjusted as needed. So to date, the results have been, we have 76 out of the 126 unique action plan were developed and well implemented. And also type of frequency of intervention as include hosted like venues. For example, I can deliver or give you a venue for training, for meeting, for everything, for the APIs and the health centers. And also the routine immunization and polio were involved in increasing RI children, 0 to 5 children and pregnant women. So we have we have seen some increasing numbers among that. Again, we had the partner developed what we call educational session, where they developed with, of course, our technical support, but they were leading it, and the message were diffused via radio and TV, and all these are supported by them. So more than 13,000 individuals were reached with messages and education session. The number of children reached also through their efforts has increased. So we have seen more than 9,000 women and even more than 1,700 pregnant women were vaccinated. And more than 6,000 children were vaccinated. And among them, we have been able to consider or to reach more than 1,000 zero-dose children. So this is part of the result also was how these non-traditional partners have been able to raise cash. So in top of their contribution, technical support, and all these venues they can give, they also raise some money to support some fees to rent a room, broadcasting messages, and also hosting event, and even for vaccine storage. And the non-traditional partner receiving, they are also recognized. There is a system to recognize their effort by the help zone. They are recognized and well included in what is happening as key partners among the, within the community. So what is the recommendation? Formalization of the non-traditional partner engagement process and its adoption through national, provincial, and zonal can help deepen non-traditional involvement and also leverage and assist better to reach or reduce the number of zero-dose children or under-immunized children. Because DRC, if you know, the country is a very spread country with a lot of challenges. So in conclusion, we want to say engaging non-traditional partner led to increased uptake of COVID, of course. And the lesson learned from the COVID-19 vaccination have been used to strengthen our routine immunization program. This approach have been potential to be demand for potential for increasing the demand and also assisting all the adults as well as childhood. I want to add that it was targeting both rural and urban areas, people in a given provinces, and including also disabilities person. So thank you for your attention.
Thank you, Dr. Djeneba. That was from DRC. Our first presenter spoke about increasing access to vaccines amongst disabled populations in Indonesia. He just came from DRC. And what I like about this is the non-traditional partners. In DRC, for those who know DRC, almost 60% of the health facilities are not owned or run by government. They are either faith-inspired or being run by the big mining companies who are doing business there. So you can't increase access if you're not engaging non-traditional partners there. From DRC, we are going to move to Nepal and hear from Dr. Sabitri. Dr. Sabitri is a nurse, a registered nurse, and she also orders a master's in population and sociology. She has about 6 years of experience in the development field, and she's going to talk to us about increasing access to vaccines and routine immunization in Nepal. Sabitri, please. We'll try to rush through all the presentations, and then we can have an open discussion at the end.
Thank you, Robert, for your beautiful introduction. I'll start with my presentation. Let's dive into it. The topic of my presentation is engaging community health worker, elected leaders, and other influential community members in communication and mobilization activities to increase COVID-19 acceptance in municipalities or rural municipalities with low vaccination. That's a mouthful. And the authors are Thaneswar, me, myself, and our colleague was Suresa, and my supervisor Ajit Kumar Karna. Actually, I would like to give appreciation to all our team members in field as well, because this is because we write this up to disseminate everywhere, but the main player of this activity were field workers, right? And I'm affiliated with the USAID system strengthening for better health activity. And as it was the consortium program, that's why we are also from Save the Children and Apt Associates. I will explain it if you want me to, okay? Thank you. We'll go ahead. Where should I? I'll start with little bit of background. Government of Nepal started COVID-19 vaccination from 27 January 2021, and it was guided by NDVP, that is National Deployment and Vaccination Plan. At first, they have included their target population as 15 years and above, but after some time, we came to know that the vaccines are also available for age group from 5 years and above, and we have started and we have added adolescent groups and age group children above 5 years of age group. And I would like to celebrate our achievement of getting 90% vaccination in our country. It's from target population. Okay. And then I will talk about our program, that is USAID system, strengthening system for better health. As you can see, it was funded by USAID, and the concept, the program which I am presenting is it's from the views umbrella of SSBH, and SSBH works in 4 major components, that is MNCS, the maternal neonatal child health and health information and system strengthening, and then after pandemic we have added another component, that is HER, health emergency response against COVID-19. And then we started it on 4th year of the big project, and on 2nd year only we added vaccination program, and the support categories were coordination and planning and review, and surveillance and information management, and third one is communication and community engagement, fourth one is vaccine administration and clinical management, fifth one was in IPC, that is infection prevention and control, and lastly we had also supported it logistics, especially in cold chain maintenance. And today the concept that I will be presenting is out of the 3rd component itself. Okay. These were the assumptions during our 4th year of work, that is 1st year for COVID. We realized that only responding to COVID won't be sufficient. And we, in 2nd year of HER activity, we started incorporating vaccination in our program, and the assumptions about, because we have already worked for 1 year in COVID response, that and we also talked in our keynote session that we have infodemia during COVID. We have lots of information, good, bad, and we had the anti-vaxxers were also infiltrating our communication system, and these were the assumptions. That's why we developed this work plan. That was vaccine hesitancy. People were hesitant about the vaccination because of doubts regarding quality, trust issues, and the information were compounded as well. And the steps of intervention, because we have thought about it during our 1st year, that's why we already have a concept paper. After that we did we thought that how to take these areas or municipalities, and we did analysis of vaccine coverage data, and then we at first we were only trying to develop a package that we could give to community health workers and leaders, but then we thought we don't know about any background, and we don't know what community wants. That's why we added another program, that is programmatic review. And then after programmatic review, the orientation package was delivered to our community health workers and leaders. Then orientation was given in selected municipalities. Then we did documentation of all of it. the major expectations, I will say, we want to know what was causing decrease in acceptance, and why are target groups not coming to vaccination centers, right? And then we also want to test if a home visit or surveying will increase this or not, and what are the doubts. And we want to hear about the stories from the community itself. And then the last two, which we do regularly, we do documentation, and we hope that government will take initiative from their self as well. And then, as I had said, we have two forms of program. One is programmatic review, which was done in 2 provinces, but only 42 events were conducted in 30 rural municipalities and 12. And then it's out of 139 rural and municipalities. And participants were in programmatic review. We included local representatives, health workers, community health worker, and in Nepal they are called FCSVs, female community health volunteers, religious leaders, and other influential community members. And during these meetings we discuss about what's happening in the municipality or their areas, and what are the factors they think that are causing low acceptance of vaccination, and strategies they have already in place or they are thinking of doing it, and what are their future plans. And like after to monitor, we came the result was action plan, so that they could see how they are improving or not in future. And during programmatic review, we already have some plans, and we also added some other programs after programmatic review, but I will only talk about community engagement. The need for mapping communities, like the municipality have low coverage, right? But there also they have clusters of people who are not getting vaccinated, rather than the whole municipalities. That's why they thought that they should identify these clusters, and need to, like other strategy was to include school children, teachers, and parents to communicate these about vaccination is going on here and here, and who is going to vaccinate, and what are the myths that are around that. That's why, and they have suggested it. And then because there was a pause during this program, that we were facing logistics problem, that we weren't getting much vaccine. And after this, the government has said they will provide as much as possible. That's why it was part of our development as well. That's why they said that if we are provided with vaccination on time, we can do it properly as well, and at least give us a few weeks or a week, so that we could inform community about the program as well. And then communication interventions. Now, after sometimes I will present you the list of places where we have these programs, and most of them are rural areas. That was your question, right? And we have seen that we were giving information, many information in social media, but the people who are not getting these messages didn't know when it's happening, or it's happening around them or not. That's why they also ask us to use different innovative methods, and I will say primitive methods, like miking, or people telling everyone that vaccination is going to happen, that they have also recommended that. It's from community. And then after the programmatic review, because you have seen that previously, one of the recommendation was to orient community leaders, FCSBs. That's why, and we also have developed one orientation package, and it was conducted in two provinces, 12 municipalities in 45 batches. It was prepared according to, the package was prepared according to RCCE, that is Risk Communication and Community Engagement Strategy, conducted in selected municipalities. The SC is Chief of Municipal Level Health Section, Health Coordinators, and health workers. They will do follow-up according to action plan of programmatic review, and then after that, we documented success, learning, and share it to all tiers, all 3 tiers of government. Yeah. And you will see the places like these were the municipalities where we conducted both activities, and the baseline was taken on November 2021, and then the inline was on 28th of February. You will see considerable rise, and the average increase was 39.11%. And then after this, because this was pilot as well as, because we initially we only planned it in 6 municipalities, but because of demand from government to increase it, increase the implementation part, that's why we increase it so much. And the major learning from these, this was okay, thank you. And there was already gap. Initially, there was already gap between health worker and community, and with COVID, people having to have social distancing, it was also again increased. And then capacity building, when we talk about community, it's always not limited to training health workers. We also should build capacity of community leaders and health volunteers as well. And mainly in Kurniawan province, that is very rural part of Nepal, the migration of workers, seasonal migration, they will migrate in some days and they will come back. Due to that, there was very less vaccination coverage in those areas. And as I already have said that we must have innovative approaches, and sometimes primitive approaches also works. That was our major learning. And thank you for bearing with my, I think, boring presentation without any pictures. Thank you.
It was a very nice presentation. That's Nepal. Our next presenter is Dr. Isaac Olufadewa from Nigeria. He's a medical doctor, researcher. He's also a youthful global leader, as you can see. He's a founder of the Slum and Rural Health Initiative that is implementing programs in a number of African countries, Nigeria, Ethiopia, and others. And he has been a great advocate for COVAX and made recommendations that have considered strengthening of vaccine access amongst adolescents and young people. He's going to talk to us about what his organization has been doing in urban settings of Nigeria and Ethiopia in overcoming challenges around vaccine equity. Dr. Isaac, please.
Thank you so much, Robert, for that introduction. So good afternoon, everyone. I know that it's, so I'm presenting on this Young People as Change Agents in Vaccination Campaign, lessons from the Youth for COVAX project in 2 African countries. So I'll be following this outline. just to like have the background to this is the fact that even though we know that vaccination is one of the most important innovations in public health, and despite this various evidence, we still have some people being hesitant, in taking the COVID-19 vaccine in many African countries. And this, we saw that manifesting especially among the young people or the youth. And this is due to several factors, some misconception, some was because of the myth, and especially about young people not falling sick. And I remember that during the fact-finding session, especially the needs-based assessment sessions, where we had like this interaction with many young people. It was one of the most interesting things because you saw them like talking about like several issues. I think this one was saying, I am a guy, you can see my big muscles while showing us the big muscles and flexing it. And we're saying like even if I get the virus, nothing can happen to me. Several other people really brought out some things that would make you, wonder for a moment, but at the same time disagree. Someone said, we have not found a vaccine for HIV/AIDS. I can't trust these health people the way they, got a vaccine for COVID-19. Another talked about the fact that the vaccine was like really produced in a hurry and so many other things. So we saw a lot of this, and this was one of the reasons why we took action. And the action was basically coming up with the Youth for COVAX project. While Slum and Rural Health Initiative is registered as an organization in 4 African countries, this was majorly in the 2 of the largest countries where we operate in, which is Nigeria and Ethiopia, and it was just in some selected local government areas in these 2 countries. We looked at, okay, what does a profile of a youth champion, what does it look like? And which was like informed our selection criteria. We looked at like young leaders coming between the ages of 18 to 35 years, currently residing in the community. They understand English because this is very important for those who will train them, and also the local language, especially when they want to have their this vaccine communication campaigns. And then they are also willing and available for the training exercise and for the community engagement events. So those were the things that we really considered, when we're choosing this 60 COVID-19 youth champions who worked on this project. So basically the objectives were to, first, we needed to understand, like, address the COVID-19 myth and misconception. We had to like co-create culturally sensitive COVID-19 vaccination messages, and the last was to increase the vaccination uptake, COVID-19 vaccination uptake in this region. So our approach, which is very important, you could see that's a picture of like some of the youth champions in Ethiopia. After like one of the training session. So we definitely involve the voice of young people because young people were very vast and very conversant with social media. Many of them already had like many of their colleagues who had like negative perception about the COVID-19 vaccine, and then they came, and then we brought out the major messages which were very important misinformation about COVID-19 vaccines, and then we worked in creating tailored messages based on the communities which they are, which they reside. For many communities in Nigeria, most of the things that we're having, like, okay, COVID-19 is a foreigner's disease, doesn't really affect us. In Ethiopia, we had like more insights about young people thinking about like the vaccine was hurriedly produced, and so it had to be tailored to the communities which we were involved in. So we definitely worked also with training these young leaders, and through a very tailored and structured training program which they were involved in. There was role-playing session where they had to like work with one another during the training, and like ensure that they can, we see how they change and persuade other young people, especially about the COVID-19 vaccine. Social media advocacy was one very important part too, because young people people were using social media, but how well were they using this to promote the COVID-19 vaccine? I remember that many young leaders had to open a TikTok account, which is like one of the trending social media accounts during that period of COVID-19 for the first time, and then how to use that, and that's an interesting part because even me, myself, I opened a TikTok account during that period. And there was this peer-to-peer education model because one thing is that some of them were medical students, some of them were like working in the health center, and then we wanted a situation where they could also train other people that would be in contact with other young people. So every COVID-19 youth champion was tasked with at least, educating at least much more than they would do to their other colleagues, 5 other young people. So that was more of the task shifting approach which we used in the program. Then definitely we worked with culturally sensitive messages. Then we had like a multi-pronged dissemination strategy, which didn't only include social media. We also included things as regarding radio stations. So we had like youth champions go on radio, answering questions from the audience, which was very interesting and very insightful. And then the vaccine communication campaign lasted between 6 to 9 months. So these are like some of the pictures you would see here where this is like the COVID-19 messages, vaccination message in the local language. I believe that's a language in Ethiopia. We have like these are like the training session. We see the young people in the community like talking to people, ensuring that they understand. We see them also during the training part of the project. So basically, this was the communication strategy that was used in the project. Physical outreach was very important because many young people were needed to. We have these newspaper stands in like many countries in Africa. I know that's where like many of the arguments really occur. And then in quotes, community policies are decided in those areas or in those places. And then those were like one of the places that we targeted. We know that young people love football a lot. They will also love watching soccer or whatever it is, and then we strategically like located, okay, where can we find other young people? And those were like the strategies that was used, during this thing. And then, during those, we definitely had like this, how do you handle, when people are arguing with you about the COVID-19 vaccination, and how do you really come out and like talk, by asking critical questions about this. And that's like some of our young leaders there, in the radio station, and where they had where they didn't just like educate these people, but also answered questions. Because one thing we discovered, especially about when it comes to changing people's perception about the vaccine, is not only about like delivering your message, but it's also about responding to the questions, to the issues that many of these young people might have, and responding to them really helps a lot in debunking many of the myths and misconceptions about the COVID-19 vaccine. So one thing is, when you create a demand for the vaccine, you have to also like ensure that you connect this with the primary healthcare agency, and that is like one of the key focus too of this, because we had to connect this, because sometimes we have like young leaders matching, their fellow colleagues to the health center to go and get the COVID-19 vaccine, which was very interesting and insightful to see. And so we had to like ensure that sometimes, some of these primary healthcare facilities could close by 2 p.m. and then the football matches closes by 3 p.m. So you inform them, before time. So they're like, oh yeah, please, you can just kindly help us do 1 more hour, because some young people will be coming to get this vaccine during this period. And that was like one very interesting thing that we saw from this COVID-19 communication campaign. Then social media campaign, that was very, very important, because many of the people when it comes to people that are against vaccination, you see them on social media. They are very vocal, and it's something that like many health professionals or many doctors, nurses, health professionals do not even know how to engage these platforms, and this is where we have to like take many of this information. And one thing we saw is the fact that we need to leverage storytelling. And I remember like one of the first set of people that had COVID-19 and then survived in Nigeria, was brought on a tweet chat session on our like organization's handle, and then we were really communicating that this information didn't just spread through the social media platforms. It was also on WhatsApp. It was also on not just Facebook, Instagram, but also like on new media like TikTok, which is very interesting. And I feel that like this is one of the major things that we need to do, leverage more of. And yeah, so this like some more pictures. You can see smiles on faces, after like really understanding many of these things. And that's like one thing, because you needed passionate young people, because the youth advocates themselves, their profiles really matter in when you want to like have this kind of campaigns, and when you want to have this kind of outreaches, because they need people pick up from their enthusiasm about the project. So outcomes, we had like over 52 different culturally sensitive and translated COVID-19 messages. We trained many young youth champions on this, and 95% demonstrated at least 50% improvement, which we consider like what we call meaningful improvements in their knowledge about COVID-19 vaccine. Because one thing is, when they say how many vaccines do you have in your country, you have to be able to respond, and many other things about. And then we saw that the increase in young people that came to collect, to take the COVID-19 vaccine, which was very important, and this was monitored with the health facilities. We had 7 radio stations sessions, which was led by young advocates, and overall we believe that we were able to directly reach over 120,000 people. So lessons learned is the fact that young leaders, their voices and creativity matter. And when people say, oh, when it comes to vaccines, young people are not willing, we discover that like they're very willing to engage, and that's like a very important thing. Community creation is important. There's a need for bi-directional flow of information, even though this was more advocacy focused than research focused because of the nature of the project. We saw the fact that social listening and then community health promotion is important. The ease, right? Accessibility also matters. So you can have motivated people, and then yet they are still not vaccinated, and you feel that your program is not working. How have you been able to connect with these primary healthcare agencies? How have we been able to ensure that we meet demand with access? Yes, and then definitely we need more bottom-up approach. Young people are willing, very, very key, very important. Vaccine communications are very effective when we listen, and then we ensure that the right message, reaches the right messenger. Young people basically worked with a lot of young people. Over just about 10% of young people were vaccinated as at the January 2022, and then we saw a lot of increase in some facilities, 32% of like increase in terms of like the young people that came, and that is very important. So we are not telling young people to reach very elderly people, but go and reach your peer, and right message must be met with the right messenger. And then scaling up of grassroots initiatives on COVID-19 vaccination is very crucial too. I love the fact that like the African Union Commission also really has a project, leveraging youth champions too, and it's in all the African countries. So those kind of projects are like the things that we're talking about. So I definitely need to acknowledge like the country coordinators, young leaders too like me, who are really doing excellent work. Mirekwa Adeshino, Takele Muleta, who is also our country coordinator in Ethiopia, the executive members and all the other project members, our TikTok trainers and every other person, really appreciate them. Also our founders, Global Youth Mobilization. So thank you very much.
Thank you, Isaac. That was Nigeria and Ethiopia experience. And lastly now, before we go into a discussion, is Doreen Tukahebe. Doreen is a research fellow at Makerere University School of Public Health. And she also holds a master's in public health. She's currently doing work around vaccine access, specifically on HPV work, and she's going to speak to us about increasing equity, vaccine equity amongst urban poor young girls Please, Doreen. After Doreen, we'll have a question and answer session.
Oh, it's up, okay. Good afternoon, colleagues. My name is Doreen Tohewe. I'm here presenting our work on behalf of colleagues Christine, Emmanuel, and Stephen on improving HPV vaccine acceptance in slums with a case study of the role of peer-to-peer education among adolescent girls in the urban poor settings of Kisenyi in Uganda. Okay, so this study, a project is based on the background that cervical cancer is the fourth most common form of cancer among women worldwide, and it's also affecting women in Uganda. And we all know, based on statistics, that nearly 90% of the deaths occur in low, middle, and middle-income countries, a reflection of global inequity, that those who are poor are the ones who are most burdened. The World Health Assembly has adopted the global strategy for cervical cancer elimination that is really targeting 90% of the girls fully vaccinated by age of 15, 70% of women all screened by the age of 35, and 90% of those that are screened and found that need treatment are able to access it. So now from that, we recognize that HPV vaccination is effective, but we all know that it has not been accessed where it is needed. In Uganda, there are efforts around all of this. We have a school-based program for HPV vaccination. We have screening, mostly integrated within HIV care, but more needs to be done. But then we also recognize, based on our discussion today around equity, that there are several people that are left behind. And in Uganda, we have a compounded problem, especially among our young people, because we have HIV within our community. Our girls have early sexual debut. By the age of 15, one in 4 girls has had sex. So you find that with all these compounded vulnerabilities, we need to increase the HPV vaccine access. And in Uganda, the vaccine was introduced in 2015, and currently we are running a 2-dose HPV vaccine series, but we still see low HPV vaccine uptake, and it's still a significant barrier. And this is more so within certain clusters of communities, like the urban poor. Some people use slums as the word, some use slum informal settlements. I'll be using urban poor within this setting. So you find that in literature, urban cities, people think that people in the urban communities have access, but then geographic proximity does not always mean easier access. So we, back around 2019, 2020, we had been interfacing with this challenge of low vaccine uptake among our girls in Kisenyi community, and we thought as a team that we could try out interventions, and we thought about the adolescents as a source of energy, creativity, and tapping into their creativity and availability to be able to increase HPV vaccine acceptance among fellow peers. And that's how we piloted the peer-to-peer education approach within this urban poor community in Kisenyi. Urban poor communities, of course, they are characterized by poor housing, poverty, a lot of congestion, but with a mushrooming population with many, many young people. So there's a lot on this slide, but I thought I could take the opportunity to walk you through the approach that we used for this study. Our target population was girls aged 10 to 14 years that had lived in Kisenyi for the last 1 year, and they had been fully vaccinated. Those were the ones we targeted in order to interest them in becoming adolescent peer educators. Okay, so that was the target population, but then also the target population that should be receiving the HPV vaccine. So as investigators from Makerere University School of Public Health, we worked with a cadre of community health workers called village health team members to identify girls that had been previously vaccinated and had received their 2 doses. So, and then we also linked up with the public health center in Kisenyi in order for them to be ready to vaccinate girls through with the referral through the study. So, as part of the intervention design, what we did after identifying, we were able to identify about 32 girls that had been fully vaccinated with HPV vaccine. We invited them to participate in initial focus group discussions. 28 of them were consented to take part in the focus group discussions by their caretakers. So after the focus group discussion, understanding why for them they accepted to take the vaccine, what they think the barriers are, why their other girls do not take the vaccine. So we're able to come up with the results, and we shared with the girls, and we said, okay, so these are the results that we have. Would like to interest you to be part of adolescent peer educators, where you reach out to fellow unvaccinated peers and interest them in taking up the vaccine. So among the 28 that had taken part in the focus group discussions, 18 expressed interest and were committed. Actually, 24 expressed interest, but then with the consultation with the VHTs thought that a few of them were not committed and could not really function as peer educators because it requires you to be able to communicate, to have the networks and friendship to do it. So with that, we interested them and we worked together. We designed, we co-designed a health education message. What should we be telling our unvaccinated friends when we meet them in the community? So we agreed that we should be telling them about the fact that there's this disease called cervical cancer that affects the reproductive health system, and if it affects you, you cannot give birth, but the HPV vaccine is available and it can protect you against cervical cancer. So that was mostly around the messaging. And then we agreed that the peer educators would engage and identify unvaccinated peers within the community, not within the schools, because in the schools, you all don't live in the same community and you cannot follow up. So you identify girls within the community to even allow opportunity to identify those that are out of school. So, and with that, we also coupled that with what we call weekly mentorship meetings with the adolescent peer educators, so that every week you meet them and talk to them and ask them how has it been being out in the community, engaging and learning and going along. And then we're able to document lessons. So that's detailed. So moving along, these are some of the photos that when we were engaging with the adolescent peer educators, learning with them, having fun with them, and documenting lessons. Some of the stories of change we learned from the peer educators that they were able to communicate the vaccine benefits and also manage anticipation for injection pain. And these are some of the quotes from them that seemed to work. And also the adolescent peer educators needed to be supported to engage the caretakers, because the caretakers were the final decision makers. Because sometimes the caretaker would refuse, even if you identify an unvaccinated peer and they say, I am willing to take up the vaccine. One other thing that was a challenge, a few things that were challenging the approach, the unvaccinated peers would sometimes change their mind at the last minute. They say, I'm willing to go to take the vaccine. They even reach the health center. They look at the injection and then they're like, I'm not taking it. So we realized that the adolescent peer educators had to have a lot of follow-up, good communication, and be supported to learn and continue engaging. And one other thing we learned that did not work was the place of of engagement and limited repeat socialization, especially with out of school. So we find that our adolescent peer educators were able to refer fellow girls to be vaccinated, but not many, they could not refer as many of the out of school girls because they lacked the friendship with them. So one of the few things that we learned about how to optimize the peer-to-peer education approach, one, the content of the message. Messaging around that HPV vaccine can prevent cervical cancer, not how the virus is transmitted through sexual behavior. So focus on cervical cancer as a disease and HPV as prevention. But then also the peer educator characteristics. I know Isaac talked about attributes. Yes, the peer educator has to be motivated, energetic, and be friendly with connections in order to reach out of schools and in school and fellow friends. And then we should be able to map out key decision makers along the decision pathway, because caretakers usually are the final decision makers. So we learned that a lot. And then health system adaptations, because after a girl is willing to be vaccinated, we had to link them to the health facility. That required adaptation with our VHTs to link them to the facility. And then we also learned that from our qualitative approach, we're able to document lessons and improve the interventions. And then we also learned that context matters. We found that within our adolescent peer educators, we could not recruit out of school adolescent peer educators because they were never vaccinated in the first place. So which demonstrated that we have to be aware about equity. And then also the COVID-19 context presented challenges in a sense that the girls that received the first dose were due for second dose around March 2020, and then the lockdown happened. It meant that they had to delay their second dose, and a few of them left the community and went back to like their rural villages. So we realized that there are these things that you have to be aware of about the context and how, and then all our peer educators were all in school, so out of school people could not be part of the adolescent peer educators. In conclusion, we learned from this study that peer-to-peer education approach is feasible in the urban poor context, even when sometimes parents would worry that our girls should not be engaging with fellow peers, they may learn bad manners, but we learned that with the VHT connection, they are able to build trust and know that our girls are safe in the community. And we also learned that all key influencers of the vaccination decision-making pathway should be mapped and engaged, especially the caretakers. And then the model can reach out-of-school girls to reduce inequities if we can vaccinate more girls and reach the out-of-schools, and then finally recruit them to also be adolescent peer educators. I would like to acknowledge the youth. They are there, they were excited, they were happy. We got t-shirts and they were branded. We recognize Sabine Vaccine Institute and the Kisenyu community health workers for the mentorship and support and linking us with the Ministry of Health and all the study participants. That's my email, thank you.
Thank you, Doreen. Now it's the opportunity for you to interact with the panel, fire them questions, or share your own experiences. There are mics. We have only one. Oh, we have a lot of questions. This is very good. The panel needs more questions.
Firstly, I'd like to congratulate everyone for such a wonderful presentation. I come from Nepal. I'm Dr. Navneet Bichha, and something that I was able to learn from Ms. Sabitri was about the capacity building in the community engagement. So this question is actually for all of you. Like, we are seeing that over time, that when we are building capacity with the female health volunteers and also the community leaders, we are seeing a level of fatigueness, you know, in our interventions. So how do we see this for effective implementation in future? Because this is something that we have to keep encouraging our community health workers. So with this, one of the lessons that I have learned with my experience in COVID-19 vaccination is that when community does not respond, you know, the service providers like community health workers, they see a level of fatigueness. You know, like, why should I go there if they are not interested? So that, how can we counterattack this kind of fatigueness over time so that we can have a future effective implementation? Thank you.
Thank you. That's a question to all of you. Just take note of the questions. Next, boss. Please come closer to the mic.
Okay. Thank you. My name is Christo from Indonesia. So all of you have presented very interesting topics, yeah, and I want to congratulate all of you for that. But I have questions specifically for Dr. Yulianto. Yeah, I'm interested in the concept of inclusive vaccination. What I wanted to ask is around the process and the result. What I meant with the process is actually what are the prerequisites, or what do you need for that kind of inclusive vaccination concept? What I saw in your video was just the RAM, the infographic, and the interpreter? Is that, or do you need something like a huge amount of people, like personal assistants or whatsoever? Yeah. And about the result, I also want to ask about the result. How many were your target audience or target people actually? Because I saw you reached around 100 plus of patients, right? Are there just those 100 people, or actually there are a lot of people, but what you can reach is only that 100? Or maybe it's related to the investment that you created for that huge project. Is it really, really, I mean, successful on your terms? Thank you.
Hi everyone, I'm Kemisola Agbawi. I work with Nigeria Health Watch, obviously from Nigeria. Thank you so much for those presentations. I think they were really insightful. I particularly learned from them because you're all presenting from really similar contexts to Nigeria, obviously except for the person who's from Nigeria. So I have some general questions and then some specific ones. I was also curious, for my colleague from Indonesia, I was also curious about how you measured success. You had mentioned how many people were reached, but what was your target from the beginning? How far off the mark did that fall? And then for the person from DRC, I was curious about the composition of your community level oversight committee, how you selected who would provide oversight, given that your NTPs were already community leaders, religious leaders. I'm sorry, I'm really feeling cold, so shivering. So I was curious about that and how effective that was in ensuring implementation. I was also curious about how you came to have only 76 unique action plans out of 126 NTPs that you had selected. And then also curious about the selection of NTPs. What did you consider? And basically, did you have criteria for selecting your NTPs? For Nepal, I have a question I think I would love to hear as many people on the panel respond to, and this question of sustainability. How, because we implement and pilot a lot of very interesting projects, and it would be really good to see how we promote ownership by the government and how they then take that on to ensure it's sustainable after we exit. I would like to hear your thoughts on that, general panel. Then for Nigeria, so there was a lot of demand generation, and we know that there were also a lot of access issues, particularly in low and middle income countries, including Nigeria. I'm curious how you, both in Ethiopia and Nigeria, how you bridged that gap. If you created a lot of demand and got a lot of people who were interested in getting the vaccines, how did you ensure that they actually got those vaccines? How did you work with primary healthcare centers? How did you work with government? If you did, and lessons around that. Then sorry, I'm not trying to hog this mic, for Uganda, I think one of the things that really resonated with me, lessons from your project, is how caregivers were not really carried along. And Nigeria, for the reason I'm asking this question, Nigeria is about to introduce the HPV vaccine into its routine immunization schedule. And I was curious how, if you had any thoughts from the implementation of your project, how you, given that the target population are actually children who can't provide consent, how do you design projects or design rollouts that effectively carry along the caregivers? If you had any thoughts to share on that. Then, yeah, I think that's it. Sorry for taking so long.
Okay, hello everyone. Yeah, thank you for wonderful presentation. But my questions are actually for Doreen and Olufadewa. My name is Mofesha Romoboale from University of Ibadan. I'm an anthropologist. I work with children and adolescents, so I'm particularly excited with your presentations. But I would not want to bother you with other details, but I have two questions, basically. And I'm wondering if, Olufadewa, I know you work with adolescents between the 18 years and 35 years old, but with young people, I'm wondering what are those challenges you can say your champions faced in participating, in the project? Because I know very well that in Nigeria, especially where you work, you are not emancipated at 18 years, especially those categories of young people you used who are more from elite background. At 18, you are not emancipated. You still need to take consent from your parents and some of that. So I would like you to talk about what were the challenges these champions faced before they could participate. Then another thing I want to ask Doreen and Olufadewa is that how were you able to motivate your champions? Was there any form of reward given to them? I think this is very important, especially when you're working with young people and adolescents. We need to talk about this. Then my last thought was, Olufadewa, you used adolescents, or young people, your champions, those who were able to speak English. And we know that in Nigeria, not all young people can actually come forward to speak English. So how were you able to eliminate the class intimidation between your champions, the group of people who are more elitist in nature, and the young people who are more of illiterate? So thank you.
Thank you. We have two more persons.
Hello, everyone. Thank you so much, Mr. Moderator and all the speaker about your wonderful presentation. I'm Zani. I'm from Myanmar. I think I'm the only one participant from Myanmar in this conference. Yes.
Great.
Yeah. Actually, I'm staying in Tham Myanmar border, working for the IRC, International Rescue Committee, for the temporary shelter in the Tham Myanmar border. Here, we cannot use refugee camps. Here is the temporary shelter. So I'm working for this as a health agency. So I would like to ask to the Dr. Isaac, because your project, Youth for the COVAX, is very impressive for me because this is a youth-led project. So that's why this is the very important and also for the infodemic issue. So I would like to know about your experience. Are there any challenging experience when the youth are working together with the adult population, like the stakeholder and gatekeeper? So are there any experience about that, and you and your team how to overcome for this? And also for the Sabitri from the Nepal, about your data during 4-month duration surprisingly increased. This is very good and I appreciate that. So the community health worker and also the community leader teams, how frequent you capacity building for them? Because we know that orientation sections, when you are package or orientation session. So after that, how frequent capacity building and refresher for this community health worker teams? Thank you so much.
Thank you so much. And lastly?
Hi everyone.
Yes.
My name is Sunday. I also work with Nigerian Health Watch.
Okay.
Yeah, so thank you to all the speakers and the moderator as well. So sitting back here, I've learned a lot of lessons that will guide future interventions. My question is around sustainability. It's around, I see a lot of peer-to-peer strategy being adopted across all our speakers. So how do you plan to manage this peer-to-peer engagement in future? Because keeping young people really motivated when you need them, yeah, it's one thing, but afterwards, do you plan to leave them? What plans do you have? Just keeping them motivated, yeah. Thank you very much.
Thank you. Yeah. So our audience, you give us just 10 minutes to respond to the questions. It's time up, but we are in a break now for 30 minutes, and I think we have used 10 minutes of the break. Each of my panelists has an average of 4 questions. So you are a very good audience. You've really fired them. So the order is, Yulianto, you go first. You answer all your questions. Then Dr. Djeneba, then Sabri, and then Isaac, and then we conclude with Doreen. You answer all the questions that were asked.
Thank you so much.
2 minutes.
3 minutes.
2 minutes.
2 minutes? Okay. Okay, I'm being short. For NAFNIN, from our side, we use the risk communication framework from Peter Sandman, outrage and hazard. So if the hazard is low, outrage is low, hazard high, outrage low, so we should do precaution advocacy, health promotion. But if the outrage is high, the hazard is low, we do the outrage management. So if the hazard high, outrage high, we do crisis communication. So it depends in what stage your situation in your country. So we do not stop the health promotion. And then for Dr. Christo, thank you so much for your question. In Indonesia, people with disability is hidden. There is no data from them in the dashboard. So that's the main challenges. That's why we conduct the FGD, the initial assessment, initial discussion to reveal the data. But there is many challenges. Health sector and civil registration agency do not connect each other in the field level. So even though we already engage in one coordination meeting, there is no one want to share the data because data, citizens' data is very sensitive regarding politics, regarding the president election. So there is no one who want to share the data. That's why we collaborate with the disabled person organization. So through the disability person organization, we reach their members and then we collaborate with mostly the social agency because in Indonesia, people with disability is under social agency. That's why disconnected data from health agency, social agency, and civil registration agency is a main challenges. Our success is not only in numbers, but only in engagement. This is also to answer the question from Nigeria. If we refer to the engagement spectrum, inform, consult, inform, involve, until engage. So we already in phase 4 engage. So we bring access, we bring control and participation for people with disability into one discussion. So people with disability can facilitate the session. People from the government agency can hear their stories, and then awareness and the emotion from the government side is being improved, that they know that there is some groups that need to prioritize. Our success is we have award or appreciation from South Sulawesi Governor from our initiative conducting last mile inclusive vaccination, and also from the MOH. And I think the main issue is inclusivity is the basis. So we need based on equity, because in people with disability, there is medical point of view, charity point of view, now is human right point of view, and based on equity. So in every health service delivery, all people with disability should be provided with facilitation, accommodation that they need. So that's means of inclusivity. Thank you.
Thank you. Yes.
Okay. Okay. With time constraint, I will just go straight to the question on how out of the 126 leaders we have organization we targeted, how do we come with only 76 action plan? So what I can say is it is a process where the partner are engaging for what they can do. So we don't push them to decide what they want to do. So we let them come and when they are ready and what they can offer. So most of the time in this process, we have realized that it is there are some people who are already ready, they want to do something right away, but we are also seeing some coming back and say, okay, I can do more of this. So that you can see the difference is like 50, and these 50 organizations are doing also community awareness. It is not like tied in an action plan, but they are doing something on an ad hoc basis. So the monitoring process with the committee we have set up at the community level also include EPI members, community leaders, and sometimes based on what they are committed for, they are invited in the health zone, let's say monitoring meeting, where they can show what they have been able to achieve. So we at MRI level now, we are also trying to develop what we call a kind of database to try to monitor it, because we are extended within the provinces itself from help zone to other help zone, but we are now extending it to other provinces where MRI is implementing. And we are also seeing a lot of demand from other partners in the country level to learn from our approach and how they can extend it. Thank you.
Next, 1 minute, please. Next. No, it's you.
I would like to answer about the fatigueness. Yeah, we see that even in COVID, for the enthusiasm from first year, it decreased so much in second year, right? And like we should not put it like siloed system. We do that health. And another like the first approach I will do is felicitating people's work. And COVID has given us so much innovation, right? That's why people were very interested at first. That's why let's keep pushing ourselves. How can we decrease it? How can we innovate everything? That I would say for your answer. And regarding sustainability, we can only hope, right? That people like government will take ownership out of it. We are giving them all the content that we have prepared during our implementation, and in examples, even after, because the project is already finished, even after that, I'm seeing that they are using these examples right now with other projects as well. That I think I cover your answer. And regarding the surprising increase, yeah, there was a surprising increase in my result, but I had said it was only a part of a very big project, and many initiatives were done from our side, even from this project only, and we have other TVs working in same area because everyone was working to combat COVID-19. And frequency for refresher, because it was a pilot project, we have provided them with job aids, basic job aids that had helped them, and we couldn't give any refresher during this time period. Thank you.
Thank you. Dr. Isaac, please.
Yeah, thank you very much for the questions. So I would answer them. So in terms of fatigue in the community, first, we believe that community work is hard work. And community members are always familiar, and they work easily with people that they are familiar with. So that's why it's very important to engage like people that are resident or locally based within the community, because that would really help, because many government or individuals or NGOs just really go to the community, someone they have not seen before, leading the projects that they are just hearing about. Definitely you would face like pushback from the community and fatigue. So ensuring that like you work with members is very critical. In terms of sustainability, for our own work, one thing that we really recognize is not just we don't mobilize champions when you need them for like a Youth for COVAX project. We now already have like as an institutional program what we call the State Health Equity Champions, which was publicized. So whether we need these young champions for hepatitis B vaccination, campaign, communication campaign, or we need them from HPV communication campaign, or even for COVID-19 vaccination campaign, it's really just continues. Another thing about sustainability is that you have to like link them to like a place or like government workers who are always there. So that's why involving the primary health facility is very critical. 3, bridging the demand access gap is linking them with the primary health facility. That's very critical. Also, some PHCs were noted to like send young people away because they felt like the vaccines were not enough for old people, and the old people were not even coming to receive those vaccines. So just going there and then telling PHCs that these vaccines would waste. There's an expiry date to this. Give the young people. That was very, very critical to the success of the project. Challenges young people face. Young people face diverse challenges. Sometimes they don't even have data to solve on their phones. And that's like a very big challenge. So like having incentive program and component to the project is very critical. When I mean incentive, like, so you want the most passionate people, but also you want to also motivate the most passionate people to be able to, so things like transport allowance, giving them like credit card, giving them data. Sometimes if you don't want them to spend the money on other things, sub directly to their lines, you know, and then you are sure that you have the credit. So just be innovative around that. In terms of, so that's also, that goes with the motivating part. So for those, Professor Omopole, a very nice question about, like, for those who speak English, yes, we wanted them to be able to speak English because they needed to, like, understand some health materials, and then definitely they not just only spoke English, but they could also speak the local language. So we didn't just, like, take people that only spoke English, but those who could speak English and the local language. And I think lastly, okay, that's the last question. So thank you so much.
Doreen, please,
Okay,
in 1
thank you.
minute.
You hear me?
In
Okay.
1 minute.
Yes, caretakers, very important. We knew that from the literature that caretakers had to consent, much as we have a law that says, well, if vaccination, a caretaker should not reject vaccination, but realize that peer educators could also be a mechanism through which we can identify the caretakers that refuse vaccination, and then we can, community health workers can engage more with the caretakers, because not always adolescent peer educators could engage with the caretakers. So we thought there were still benefits with the peer educators. Some of the challenges, yes, most of our peer educators were in school. So during like December time when they had exams, you find that they have limited time to engage. And of course, them walking around in a slum setting, their safety, their well-being, and it was important for them to be linked to their community health workers who offer that sort of protection and linkage to safety mechanism in the community. How did we motivate them? Mostly we believe from their feedback that the training and the linkage and being called peer educators, that motivated them to be part of a community and continue to learn from each other. They made friends, they played games during the mentorship meeting, so that enabled them to stay, to keep participation. And in a way, it linked into sustainability because they were able to form an HPV vaccination club. Of course, it was HPV specific, but we think it can expand into like a vaccine club that can function in a community linked to a health facility or even in a school. So those have been some of the sustainability mechanisms. And now the health center knows that these peer educators are in the community and they are a resource. They draw on them for any of their interventions, and they continue to support several interventions through their community health workers, even when we are not doing the study anymore. So we feel like we've been learning a lot, and we think there's still room for peer educators and adolescents to support vaccine acceptance. Over.
Thank you so much. Please join me in thanking our panel. Thank you so much, and thank you, the audience. And I also want to thank the organizers, Sabin Institute, UNICEF, and Gavi. There is a poster presentation going on now. We're in a break until 3:30, but the poster presentation begins at 3:30, and it's on demand generation and social listening, combating misinformation. So you can enjoy that. Thank you so much.